So I'm going to get started as people are joining in. And thank you for joining us again in our virtual seminar series. Today, I'm very delighted to introduce Dr. Kelly Metcalfe, a professor at the Lawrence S. Bloomberg Faculty of Nursing and the Faculty of Medicine and Department of Surgery at the University of Toronto. She's a senior scientist at the Women's College Research Institute and currently holds a Bloomberg Professorship in Cancer Genetics. She is Associate Dean of Research at her faculty. Dr. Metcalfe received her Bachelor's of Nursing in 1996 from the University of Western Ontario and her PhD in 2002 from the Institute of Medical Sciences at University of Toronto. Her research focuses on the prevention and treatment of breast and ovarian cancer in high-risk women, most specifically those with a BRCA1 or 2 mutation. She has led international studies resulting in seminal research papers on the topic of the treatment of BRCA-associated breast cancer, and is using these findings to test new models of care to ensure that women have access to genetic testing at the time of their cancer diagnosis to make informed decisions about their treatments. She is a fellow of the Canadian Academy of Health Sciences, the American Academy of Nursing, and a member of the New College of Scholars in the Royal Society of Canada. She has received numerous awards and most recently received the Women of Action Scientific Award from the Israel Cancer Research Fund. So I'm very happy to introduce a longtime colleague and friend, Dr. Kelly Metcalfe, who will talk more about her program of research aimed at elucidating the role of treatment in hereditary breast cancer management. So thank you, Dr. Kelly Metcalfe. And again, a reminder, please post your questions in the little question box. Thank you for being here today.
Thank you, Joanne. And thank you all for joining us again for another one of our virtual Lunch and Learn series. I'm glad that you're able to join us. So today I'm going to talk about the treatment of hereditary breast cancer. And when we're thinking about hereditary breast cancer, we most often think about BRCA1 and 2. So I'll spend a lot of the time talking about that today. And maybe at the end, we can touch a little bit on some of the other newer cancer-causing genes that we're thinking about now that we're doing panel genetic testing. So let's get this going here. So I'm just going to remind you, everybody probably knows this information, but I just want to remind you about a couple of things when we're thinking about breast cancer risk in women with a BRCA1 or 2 mutation. And you can see the risks to the age of 80 there for BRCA1, 72%, and for BRCA2, it's very similar. But what I want to draw your attention to is the ages of onset of these cancers. So we're talking about breast cancers that are happening in the 30s and the 40s. Again, there's some that are past the age of 50, but we're seeing a lot of these cancers at an early age. And so this has implications both for screening, and that's often why we start screening at a very young age for BRCA1 and 2 mutation carriers. But it also has implications when we're thinking about treatment and we're thinking about curing those breast cancers, because these women still have a lot of years to live in their lifetime. It isn't like an 80-year-old woman being diagnosed with breast cancer when we know the average lifespan of a woman in Canada is just over 80. So we have a lot of years to think about what could be happening after a woman with a BRCA1 or 2 mutation is diagnosed with breast cancer. I also think we have to think about some other things as well when we're thinking about this in terms of where a woman is in terms of her life stage. Often these women are in new careers, they may have young children. So there's a lot of things to think about when these women are thinking about what type of treatment might be best for them. So in addition to having that elevated breast cancer risk that we all know about for BRCA1 or 2 carriers, when a woman is diagnosed with a breast cancer and she has a BRCA1 or 2 mutation, she also has an elevated risk of developing a new cancer. And that can be in the ipsilateral breast, which is in the same breast where that initial breast cancer was diagnosed. And you can see it's about a 1% risk per year for these women to develop a new cancer in the same breast. She also has an elevated risk of developing a contralateral breast cancer. So that's a new cancer in the opposite breast. And you can see that this risk is elevated. It's about 2% per year, maybe a little bit higher. And where it's especially interesting in terms of the elevated risk is in our women that are diagnosed under the age of 50 years. So you can see that this is over a 2% risk per year of developing a contralateral breast cancer. So when we're thinking about women who are diagnosed with breast cancer, we need to think about not only treating that first breast cancer to ensure that we're minimizing the risk that she will have a recurrence and die of her breast cancer, we also need to think about preventing that second breast cancer from happening. And that's unique to women with a BRCA1 or 2 mutation as compared to a woman who has genetic testing and is found not to have any genetic mutations. So when we think about the timing of genetic testing, it's especially, it's important to think about when a woman can have genetic testing in her lifetime. So she could be tested before breast cancer diagnosis, and that may be some of you who are joining us today. So you learned that you have a BRCA1 or 2 mutation. You've never been diagnosed with cancer. We are going to really target our efforts on screening so that if you do develop breast cancer, we catch it at an early stage. And we're also thinking about prevention at that time as well. So are you interested in having a prophylactic mastectomy to reduce your risk of developing breast cancer? But when we're thinking about women who have a diagnosis of breast cancer, we need to think, is it best to test them at the time of breast cancer diagnosis? Or is it better to let them get through their treatment, get through that initial distress associated with a new breast cancer diagnosis, and then we'll think about genetic testing at a later time? So that's a question that I've been very interested in looking at, and I'm going to share some of the results of some of the research that we've been doing at looking at these with these particular questions in mind. So let's think about first about the treatment of women with BRCA-associated breast cancer. So the question that we were thinking about when we first started doing genetic testing, and I came to Women's College back in the late 1990s, was thinking about women are presenting with breast cancer. They have a BRCA1 or 2 mutation. Should they be receiving the same treatment that we would be offering a woman who doesn't have a BRCA mutation? So someone what we would call sporadic breast cancer. It's not due to one of these genetic mutations. We know that typically treatment for breast cancer can include a surgery. So that could either be a lumpectomy, it could be a mastectomy, or it could be a bilateral mastectomy where both breasts are removed. A woman could have chemotherapy. It could be done before surgery, which we call neoadjuvant chemotherapy, or it could be done after surgery, so adjuvant surgery or adjuvant chemotherapy. There are other therapies, some newer therapies, and I'll talk about one of them today, which is a PARP inhibitor. And a woman could also be offered oophorectomy as part of her treatment for breast cancer. So let's first start talking about surgical treatment, because this is often the first decision that a woman needs to make in terms of the treatment of her cancer. So we know these three different options that I've just mentioned a couple of minutes ago, thinking about how a breast cancer could be treated surgically. So we're really thinking about the local control of this cancer. We want to get that tumor out of the breast. So either we can take just the tumor and a little bit of tissue around it, which is called a lumpectomy. The entire breast could be removed, or both breasts could be removed. And so this is a decision that a woman makes with her surgeon. There are many different factors that go into this decision-making related to the cancer itself, as well as there may be some personal decisions that's made in relation to the type of surgery that you want. What we do know, though, in the general population, when these three different surgical treatments have been compared, is there is no difference in survival associated with any one of them. So there is sometimes the idea floating around out there that if you remove both of your breasts, you're going to have a better survival than someone who only removes the tumor and has radiation therapy. And that's not the case for the average woman with breast cancer. We do know, though, it's different for women with a BRCA1 or 2 mutation. So this was a large study that we did at Women's College, and it involved women from throughout North America who had a BRCA1 or BRCA2 mutation, were diagnosed with breast cancer. And we collected information on their cancer. So we were looking at all of the information about their cancer. And we also looked at the treatments that they received, including their surgical treatments, because we wanted to understand, for these women, is it better that they have more surgery, or is it okay that they just have what we would typically be offering the average woman with breast cancer? So in this study, we compared women who had a bilateral mastectomy, so the women who had both breasts removed, and we compared them to women who just had a unilateral mastectomy, so just the breast removed that had the tumor. And what we found was that when we followed these women for up to 20 years, and these numbers are sometimes a bit confusing, but what it means is that by having a bilateral mastectomy, these women were 50% less likely to die of breast cancer compared to women who had a unilateral mastectomy. So in this case, a bilateral mastectomy was better at preventing a woman dying than just having a unilateral mastectomy. So this is quite different than what we observe in women who don't have a BRCA1 or 2 mutation. So what this tells us, though, is that at the time of surgical decision-making, it's important to know if you have a BRCA1 or 2 mutation. So this is a figure that shows this, and this shows, if you look on the bottom here, it's going from 10 to 20 years after the initial breast diagnosis. So we cut off the figure here at 10 years. And what we see is that these are separating, these curves. And what this is showing is these are, on this line here, are women that have had a bilateral mastectomy. And on the light black line is the women who've had a unilateral mastectomy. And what this shows is that the women who had bilateral mastectomy, both breasts removed, had a much better survival than women who had just a unilateral mastectomy. And we have to think back to the reason why this might be happening. We talked a little bit earlier about the elevated risk of women developing a second breast cancer. So by having this surgery where both breasts are removed, we're actually preventing that second breast cancer from happening, or maybe not preventing, but significantly reducing the risk of developing a new breast cancer. And by reducing the risk that a woman ever gets a second breast cancer, we're reducing the risk that she will die of that second breast cancer. So it's important to be thinking about that as well. So when we looked at this group of women, and again, it was a large group of women, if a woman developed a second breast cancer in the opposite breast, so a contralateral breast cancer, her risk of dying doubled. In the 20 women who died between those 10 and 20 after that initial diagnosis of breast cancer, 55% of those women had a secondary breast cancer. So 3 of them had it in the same breast and 9 contralateral breast cancers. So we have an opportunity at the time of breast cancer diagnosis, when a woman is having surgery, to prevent those new cancers from ever happening and reducing her risk of dying. So that's the primary surgical treatment and what we know about that. So what about oophorectomy? And there's a lot of talk about oophorectomy in terms of preventing ovarian cancer, and it's something that is recommended for women with BRCA1 or 2 mutation. But is there an impact on women who have previously been diagnosed with breast cancer? Is there an impact on survival? And this, again, is that same cohort of women that I've been describing to you that have a BRCA1 or 2 mutation and had breast cancer. And you can see here that if a woman had an oophorectomy, had her ovaries removed, she reduced her risk of dying again by about half. And that's just cancer, or that's just death due specifically to the breast cancer. So it's not any other cause. When we look at all-cause mortality, you can see there's an even greater risk reduction, a 65% reduction in mortality associated with an oophorectomy. Because remember, it's helping with the breast cancer specific death. So it's preventing, or it's reducing the risk of dying of that first breast cancer, but it's also reducing the risk that these women would get ovarian cancer and die of ovarian cancer. So it's having an even more profound effect on all-cause mortality, which could include breast and ovarian cancer. So there have been some other studies that have looked specifically at BRCA1 and specifically at BRCA2. And again, we're seeing these survival advantages associated with an oophorectomy. So this is a BRCA1 paper that we did some work with our colleagues in Poland, looking at the survival rate in women with stage 1 to 3 breast cancer with a BRCA1 mutation. And you can see overall the survival rate was 78% at 10 years. And specific, if we're looking just at mortality related to breast cancer, it was even higher at 84%. If we look at what happened when if a woman had an oophorectomy, she reduced her risk of all-cause mortality, so that could be from breast cancer, ovarian cancer, by 59%. And again, we saw a very significant reduction in breast cancer specific mortality in ER-negative tumors with an oophorectomy. So again, providing further evidence that this isn't just preventing ovarian cancer and reducing the risk of dying of ovarian cancer, it's also having a very important effect on survival in women with a previous breast cancer. And we saw something very similar in BRCA2 as well. So this is looking at 10-year survival in women with an oophorectomy compared to women without an oophorectomy. And you can see on the top line here, the darker gray line, this is women who had an oophorectomy. And you can see this is at 10 years after their breast cancer diagnosis, that there's almost a 90% survival if a woman had an oophorectomy. If we look at the women without an oophorectomy, so that's this line, you can see their survival is not nearly as good at 10 years, with about a 59% survival. So again, this really provides evidence as to the importance of knowing if you have a BRCA1 or 2 mutation when you're making decisions about your cancer treatment. So we've seen that it's effective in terms of breast surgery. We're also seeing now it's really important to know if you have a mutation when we're thinking about the effectiveness and whether or not you should have an oophorectomy as part of your cancer treatment. What about chemotherapy? So this was a study that we did, again, with our colleagues from Poland, looking at should all women with a BRCA1 mutation have chemotherapy with early stage breast cancer. So these are all stage 1 breast cancers. Often these women wouldn't be offered chemotherapy if they have stage 1 breast cancer in the general population. So what we first did was we looked at a group of women that we had data on, long-term data on, from Women's College who did not have a BRCA1 or 2 mutation. So some of these women had chemotherapy, some did not have chemotherapy. And in the dark line, it's women who did have chemotherapy. In the light line, it's women without chemotherapy. And you can see there's barely any difference, suggesting that chemotherapy in stage 1 breast cancer isn't really going to offer any survival advantage on average. So we have very high 15-year survival rates at 90%. These are women with very early stage breast cancer with generally a very excellent prognosis. When we compare that graph, and you can see just looking at the differences in the graphs that there's a difference here. So this second graph shows women with stage 1 breast cancer, again, very early breast cancer, but they have a BRCA1 mutation. And you can see the dark line again is women who had chemotherapy. The light line is women without chemotherapy. And it's very obvious to see the difference at 15 years in terms of survival rates. So This shows us, though, if we can compare these two graphs, by giving chemotherapy to BRCA1 carriers with stage 1 breast cancer, it's very close to what we would see in women without a BRCA mutation. If we don't give chemotherapy to these women with stage 1 breast cancer with a BRCA1 mutation, we really see a much worse survival rate in this group of women. So really, again, thinking about the advantage of having chemotherapy, even with stage 1 breast cancer, if you have a BRCA1 mutation. Again, more evidence suggesting that knowledge of BRCA status is really important when thinking about the treatment that is most effective. What about other treatments? Thinking about that. And this was a study that just came out last week. It's very exciting. One of our earlier presentations, we heard about PARP inhibitors. Olaparib is a PARP inhibitor. And traditionally, in most of the research that's gone on up to date, it's really been offered in the metastatic setting. But this was a study that was looking at the use of olaparib in patients with BRCA1 and 2 mutations. And all of these women were treated with surgery and chemotherapy. So they could have had chemotherapy prior to their surgery or after their surgery. So neoadjuvant or adjuvant chemotherapy. And when they were done that, they were randomized. And some of these women took olaparib, which is a PARP inhibitor, and some of these women had a placebo. And they looked at survival over a period of time. And they actually stopped this trial early because of the difference in survival between the two groups. And what we see at 42 months was those in the olaparib group, there were 59 deaths. Those in the placebo group, there were 86 deaths. So you can see the difference in terms of survival at 36 months. So at 3 years, women in the placebo group had an 88% survival compared to 92% in the olaparib group. And they will continue to follow these women to see if those curves actually separate even further in terms of survival. But really exciting new research that's using genetic information to personalize treatment. So we'll see what happens with this. Again, it's very new. It was just published last week. In terms of the how or if that this is put into clinical practice for BRCA1 or 2 mutation carriers. So looking at some of the information and the data that we have on treatment, we can see that there's improved survival in BRCA1 and 2 mutation carriers who have breast cancer with the use of bilateral mastectomy, oophorectomy, chemotherapy, and potentially now thinking about the use of olaparib or a PARP inhibitor as part of their treatment regime that they go on during this cancer treatment journey. So the questions that we really need to think about then, well, we have all of this evidence now that treatments can be personalized and women would be able to, it would be good for women to know whether or not they have a BRCA1 or 2 mutation. So there's a few questions we need to think about. Should all women with breast cancer be tested or just selected women like it is right now? So you have to meet a certain criteria. It's based on your family history. It's based on your age of diagnosis, ethnicity, etc. When should women be tested? So should it be at the time of breast cancer diagnosis, or should it be after a woman is done with her treatment, she's gotten over that, that distress that comes along with a new breast cancer diagnosis, and do the testing after? And if we are to offer women with breast cancer genetic testing, or we are to start offering at the time of diagnosis, how are we as a health system going to support this for all women? So this was a consensus guideline that came out about 1.5 years ago from the American Society of Breast Surgeons. And what they suggested was that genetic testing should be made available to all women with breast cancer. It doesn't matter if you don't have a family history or if you're not diagnosed at a very young age, but this should be available to all women. And that's not to say that all women would be interested in having genetic testing, but many would be. So that needs to be available to them. So when we think about how many women with breast cancer actually would have a mutation in a cancer-causing gene, it's important to think about the percentage of these women that would have a mutation. And this was a study that was done in the US where they actually looked at consecutive patients that came in with a new diagnosis of breast cancer. So none of these women had to meet a certain criteria. They tested everyone. And what they found was this was close to 500 women. You can see the total number up here is 488. And when they looked, so they were doing a panel genetic test that some of you may have had. Some of you may have just had testing for BRCA1 or 2, but now we're doing a panel test generally, which includes genes other than BRCA1 and 2, but also still includes BRCA1 and 2. And you can see here that 10% of these women, they were unselected, no risk factor for having a genetic mutation. 10% of these women had a mutation in one of these genes that are related to breast cancer. So that's a pretty high rate. And maybe that is cause for us to test all women with breast cancer. So then we have to think about when they should be tested in relation to the breast cancer diagnosis. And remember, we talked about this earlier about the timing of genetic testing. It can be either at the time that they're diagnosed or after. And again, the focus of why we would do each of these at a different time point are different. If it's at the time of diagnosis, we really want to personalize her treatment to increase the chance that she'll survive her breast cancer. And if it's after a breast cancer diagnosis, we need to think about preventing those new cancers that we've talked about, including new breast cancers and an ovarian cancer. So let's think about genetic testing after a breast cancer diagnosis. So a woman has had her diagnosis, she's had her treatment based on the best known evidence related to her actual tumor. And then she finds out potentially years after that she has a BRCA1 or 2 mutation. Then what does she do? And this was a study that we did with some of our colleagues all over the world, actually, in North America and in Europe. And we looked at women who had a diagnosis of breast cancer and then after had genetic testing and found out that they had a BRCA1 or 2 mutation. We wanted to know what they did with that information in terms of electing to have a contralateral prophylactic mastectomy at that time. So removing the breast that didn't have the breast cancer. And what we found was that there was a difference in uptake of this surgery depending on where a woman lived. So if she lived in Europe and was diagnosed with breast cancer, only 6% of these women elected to go ahead and have their opposite breast removed preventatively. In North America, it was higher. It was 29%. So 29% of women elected to go on and have their contralateral breast removed to prevent that new breast cancer from happening. And what was interesting was when we looked at this, so you can see the yellow line includes women from Europe, and the blue line includes women from North America. And we know the uptake of the contralateral prophylactic mastectomy was low in women from Europe and a little bit higher in women from North America. And what this graph is showing us is the number of women who got a contralateral breast cancer after their initial diagnosis of breast cancer. And you can see women in Europe were significantly more likely to be diagnosed with a contralateral breast cancer. And it's not surprising because we know their uptake of the preventive surgery is much lower than what we observed in North America, where there's a lower risk of developing a contralateral breast cancer. And we know from our previous research that this will probably lead to a difference in survival in these two groups of women. So this really shows us then that if we do genetic testing after a woman has done her cancer treatment, a minority of women will elect to go on and have a contralateral prophylactic mastectomy. So what about doing genetic testing at the time of a breast cancer diagnosis? This was a study that we did, and some of you may have been involved in this study. It was called the Rapid Genetic Testing Study. And we were interested in testing women at the time of breast cancer diagnosis. We wanted to know that if we provide this very fast genetic testing, a woman gets her results back before she has her surgery, does it have an impact on her decision-making related to the type of treatment that she decides to have? Because if it doesn't, maybe it's not worth doing this testing at the time of diagnosis. There's so many other things going on at this time. She's seeing a surgeon, she's seeing a medical oncologist, a radiation oncologist, and dealing with all of these other decisions that are so important for her. I was also very interested in the psychosocial functioning. So if adding genetic testing at the time of breast cancer diagnosis was harmful in terms of the distress that a woman was already receiving or already experiencing, were we causing her more distress by also adding genetic testing on top of everything else? And we were also interested in satisfaction. So in this study, women were referred by their surgeons. She came in to see the genetic counselor. She had in-person genetic counseling, and we got her results back within 10 business days. And these women completed questionnaires before they had genetic testing, 1 week after genetic testing, and 1 year after genetic testing. The eligibility criteria was slightly different than what the province has in terms of eligibility for genetic testing. We were a little bit less strict in terms of who could have testing. So these women all had a diagnosis of an invasive breast cancer. She hadn't had a previous prophylactic breast surgery, over the age of 18 and able to read and understand English so she could complete the questionnaires, and no previous genetic testing. And in addition to all of those, she had to meet one of the following. She had to be Jewish, or have triple negative breast cancer, or be diagnosed with breast cancer under the age of 50, or have a family history, or have synchronous bilateral breast cancer. So we finished this study. We recruited over 1,000 women at the time of breast cancer diagnosis from 4 hospitals in Toronto. And you can see here, so 1,000 women, we identified 60 mutations in these women. So about a 6% uptake rate or incidence rate of BRCA1 or 2 mutations. You can see these women are young, diagnosed on average in their 40s. And of the women that we tested, you can see here, 45% of them didn't meet criteria for genetic testing in the province of Ontario. So these 45% of women would never have been offered genetic testing. And when we look at the results of these, so you can see here BRCA1, BRCA2. For BRCA1, 9% of the women who we identified a mutation in did not meet criteria. So we would have missed these women if we relied on the Ministry of Health criteria for genetic testing. And 22% of the BRCA2 carriers would have been missed. So that's a lot of women that wouldn't have been offered genetic testing, wouldn't have known that they had a BRCA1 or 2 mutation at the time of breast cancer diagnosis. So what did these women do in terms of their treatment decisions? You can see here bilateral mastectomy. So those women with a BRCA1 or 2 mutation, 72% of them elected to have a bilateral mastectomy, compared to about 19% of women with a negative genetic test result. So this 72%, remember we talked earlier about the uptake of contralateral prophylactic mastectomy after learning that you had a BRCA1 or 2 mutation that was after a breast cancer diagnosis. And we remember that only 29% of women in North America elected to have that additional surgery. So quite different when we're thinking about uptake rates, depending on when a woman is offered genetic testing in relation to her breast cancer diagnosis. We also, within that first year after breast cancer diagnosis, 40% of the BRCA1 and 2 mutation carriers had a prophylactic oophorectomy. And I think that this really, really speaks to the women's motivation to use this information to make decisions. And, you know, there's a lot going on in that first year after a breast cancer diagnosis in terms of the treatments and the time that these treatments take. So the fact that 40% of them actually were able to get in and get their ovaries removed within that first year, I think is quite remarkable. And I suspect that when we look at the longer term data, we'll see a much higher uptake of oophorectomy. So an important question, like I said, is about the psychosocial functioning. If we're doing this, are we causing more distress for these women? So we looked at women at the time of genetic testing. So before they saw the genetic counselor, 1 week after they received their genetic test results, and then 1 year after. And we looked at cancer-related distress, we looked at depression, and we looked at anxiety. And what we were looking at was whether or not there were differences between women who were identified with a BRCA1 or 2 mutation and those who had a negative genetic test result. In this graph, we've also included women with a variant of unknown significance as well. So you can see there are no differences. And when we statistically looked at these differences, there were never any significant differences in cancer-related distress or anxiety at any time point. The only significant difference that we saw was at 1 year when we were comparing our BRCA positive to our negatives. And what we saw was actually that women with a BRCA1 or 2 mutation had significantly lower levels of depression than women who had a negative genetic test result at 1 year. So this data really suggests to us that finding out that you have a BRCA1 or 2 mutation at the time of breast cancer diagnosis doesn't really have an impact on your psychosocial functioning. It isn't causing more psychosocial distress, depression, or anxiety at any time point in the women's trajectory. And it's really that 1 week that we were concerned about, because again, that's the time when generally women are experiencing the highest levels of distress during a breast cancer diagnosis. And you can see it's the normal trajectory that we would expect to observe for women with breast cancer, that initially distress, depression, anxiety are at the highest at the time of diagnosis. And then over time, it's going to decline. And it really doesn't matter if you have a BRCA1 or 2 mutation or not, that all of these women experienced that decline and they got better. So we've talked a little bit about the treatments, why it's important for women to know this and know it at the time of breast cancer diagnosis. But what if we were going to open it up and allow all women to have genetic testing? How would we be able to support that? So this is some data that was led, the study was led by Andrea Eisen at Sunnybrook, and I was on this panel with her, and we looked at the volumes of genetic counseling in Ontario. And you can see there between 2007 and 16, if we're looking at the volumes of referrals, the increase is so significant. However, we haven't seen the significant increase in the number of genetic counselors to be able to counsel all of these women. And even since 2016, just recently, the criteria for genetic testing has actually expanded slightly. So I expect we're going to see these numbers go up even higher. And so we need to be thinking about how we could deliver genetic testing and counseling differently to be able to meet these patient volumes that we're expecting. And you can see the wait times across the province are quite different in terms of some women are waiting a really long time to access genetic testing and counseling services. So this was a review that was done by Gina McQuaig at Princess Margaret as part of her PhD. And we were looking at the different models that exist out there. If we needed to look at delivering more genetic counseling and testing, how could we do it? So one of the models is called direct genetic testing. And with that, there's very little pre-test genetic counseling. So typically many of you would have come in, you met with a genetic counselor, you discussed everything, and then you decided to have genetic testing. With this, it's a little bit different. Women don't come in to visit with the genetic counselor. They receive some written information, videos potentially, and there has been some evidence that this may be an effective model. Where we don't know if it's effective, though, is at the time of breast cancer diagnosis. So can we offer this type of model to offer rapid genetic testing at the time of breast cancer diagnosis where we don't offer any pre-test counseling? So that's a study that we're doing right now at Women's College. We are offering rapid genetic testing to women across Canada They don't have to live in Toronto and be able to access our wonderful genetic counselors at Women's College or any of the other centers. They can actually, this all can be done from home. So we know at the time of breast cancer diagnosis, like I said, they're seeing a lot of different specialists at that time. So to eliminate the need for an in-person visit to be able to do genetic counseling is potentially an advantage for these women, but we have to evaluate that to make sure that this is an effective model at this point in a woman's breast cancer treatment. So we're doing a panel genetic test in this study as opposed to just BRCA1 and 2 like we did in the first study. We send a saliva kit to women. She provides the saliva sample and then couriers it off to the lab. And these results are available within 10 days. And then the genetic counseling is really focused on the women who have a mutation and who need that extra support in terms of understanding what that means and using that information to help make treatment decisions. And we are looking to enroll 1,000 Canadian women at the time of breast cancer in this study. And looking at the outcomes like we did in the first rapid genetic testing study to see if there's differences, because in that previous study, we offered the very traditional model of genetic counseling. So to date, we've tested over 200 women. And interestingly, about 25% of these women have self-referred into the study. So for this study, they don't need a surgeon to refer them in. They can refer themselves into this study to ensure that we're increasing access to genetic testing across the country. So they're not relying on their healthcare provider to refer them into the study. So to date, just over 10%, so close to 11% of these women have received positive genetic test results. You can see the different genes there. It's not just BRCA1 and 2, but we have ATM, carriers, CHEK2, PALB2, and PTEN. And about 11% have received a result, which is a variant of unknown significance. And when we took a quick look at the data from these 206 women, 94% of them were satisfied or very satisfied at 1 week following genetic test result disclosure. So some encouraging evidence as we're embarking on this study that this may be an effective model for these women at the time of breast cancer diagnosis. So where do we go from here? I think we have to go back to what the ultimate goal is of genetic testing for women with breast cancer. We want to reduce the risk of dying from that first breast cancer. And I think I've showed you some evidence today about how we can do that. We want to reduce the risk of a second breast cancer. Again, we have evidence now. We can use that information. We want to prevent other cancers from happening, like ovarian cancer. And then we need to think about the relatives too, because we now have this information from women with breast cancer that can be shared with their relatives, many of whom would not have been diagnosed with breast cancer. And we can work together to reduce the risk of those relatives ever getting cancer, or if they do get cancer, it's diagnosed at a very early and treatable stage. So I think we're making really good progress in terms of meeting these ultimate goals of genetic testing. So how are we going to realize that goal, though? We need to think about personalizing treatment for women with BRCA-associated breast cancer. Women need to know if they have a BRCA1 or 2 mutation to make these decisions so that they can ultimately increase their chance of survival. We want to see as many women survive these breast cancers as possible. We also need to think about new models. And I think the one that we're testing at Women's College is a first start in terms of thinking about how women can access rapid testing. There are other models that are being evaluated, looking at the surgeon offering the genetic testing. So I think together across the country, across the world, we're thinking about new ways to be able to deliver genetic counseling and testing, because we just can't keep doing things the way we've been doing just because of the number of people that need to be tested. We also need to think about other cancer predisposition genes like PALB2 and ATM, CHEK2. These newer genes that we know less about, we're really back into the stage where earlier when I presented all of that work on BRCA1 and 2 and the treatment, looking at the effectiveness of treatments, we're now doing that for these other genes. So we have a study going on now in POLB2 and ATM and CHEK2, women with breast cancer who have mutations in these genes, and collecting all of their treatment and clinical information to try to determine what the best treatment is for women with mutations in some of these genes. So we still have a lot of work to do. And I'd like to end there. I'll stop sharing and open it up for questions. I hope I've been able to explain where we are, and I think we've made such great progress over the years, and many of you may have been involved in this research. So I thank you for continuing to contribute to research, because many women are there is an advantage for many women by you participating in this research. So thank you.
So thank you, Dr. Kelly Metcalfe, for a very informative presentation. We have a lot of questions that I'm going to try to get through. Before I start the actual content questions, a lot of people are asking about these virtual seminar series, and they are posted on our website for you to access. I don't seem to have a way to put the link in, but if you go to the Women's College website and go to our unit, there should be if you scroll down, there's a part that says virtual seminar series. So these should be posted. It may take a few weeks for each seminar to get there, but they will be there shortly. So there were quite a few questions about genetic testing and access to genetic testing, which you did talk about. And a lot of these have to do with when women should get tested, when their daughters or family members should get tested. And you've talked about access to genetic testing and counseling, and there is a lot of change happening. But maybe you just want to provide a little bit of insight about, you know, the fact that right now you have to meet criteria. However, our group is allowing individuals to self-refer into genetic testing. So if you want to get genetic testing but don't fit the current eligibility criteria, you can sign up for a study called the Screen Project. There is a small fee, but you can get genetic testing for BRCA1 or 2 if you don't meet the criteria through our research program. But do you also want to give a little bit more insight about those who might be eligible? There's a lot about whether their Ashkenazi Jewish makeup matters, their age, etc.
Okay. So it depending on where you live, every province has slightly different criteria, although it's generally the same. So what we're looking at is whether or not you have cancer, because if you don't have cancer, there has to be something going on in your family, etc. If you do have cancer, we're looking at your age at diagnosis. So young onset breast cancers, we're looking at ethnicity, so Jewish. We're looking at whether or not you have triple negative breast cancer, because we know that the frequency of mutations in women with triple negative breast cancer is higher. So there are criteria. Family history obviously is another one. So if you have questions, though, I would suggest that you talk to your genetic counselor, get a referral if that's something that you're interested in. For the rapid genetic testing study, I've told you a little bit about the criteria there. Again, it's a little bit more relaxed than the ministry criteria. But women, like I said, they can go on, if you look up rapid genetic testing, Women's College Hospital, it'll take you right to the website, and you can self-refer in right from there. So if you're not sure about your eligibility criteria, you can self-refer yourself in, and we will check the eligibility criteria to make sure that you meet that. If you don't meet criteria for either the rapid genetic testing study or to be tested free through the Ministry of Health in Ontario through OHIP, you can refer yourself into this Screen Project that Joanne was talking about. And that's for anybody across Canada over the age of 18. You don't have to meet any criteria. And it is genetic testing that's done relatively quickly. And we have a centralized genetic counselor at Women's College who does give you the genetic test results. There's no pre-test counseling, again, like the rapid genetic testing study. And we get the results back, and those are disclosed to you. If you don't live in Toronto and you have a positive genetic test result, you are referred to a local genetics clinic where they will continue with your follow-up care. So even though you don't live in Toronto and you don't have access to the counselor, we want to ensure that you are receiving follow-up care, because this is, there's a lot that goes on after you're identified with a mutation. We want to make sure you're having screening, that you're having your oophorectomy at the age that you should be having it. So it's really important to have that connection with healthcare provider after you've had your genetic test results back, to make sure that you are adhering to the recommendations about how to manage your cancer risk. And if you were tested 20 years ago or 25 years ago, they may have changed. So it's time to go back and see your genetic counselor, or we have a clinic at Women's College called the HBOC clinic, where it's a management of the entire spectrum of things that could be going on. We're thinking about your breast, we're thinking about your ovaries, we're thinking about your psychosocial health, we're thinking about if you have a gene other than BRCA1 and 2, where you have an elevated risk of another cancer, we're referring you to those specialists. So it's really taking care of everything that needs to go on for you in the management of your cancer risk.
And like you just mentioned, if you were tested for mutations in BRCA1 or 2 quite a while ago, things have changed. So it's very important to keep that communication flowing with your genetics team in case you qualify for more updated testing.
Yeah.
And just before we switch to the next question, some of you are asking about age at genetic testing. I think legally that is 18. But talking to your children and your family members is a challenging topic. And actually, one of our social workers created a video on how to talk to your children or family members about a potential mutation. And that's also on the Women's College website. And Emma, our social worker, will probably be talking about that sometime in the fall when she gives her presentation. So stay tuned for that.
Yeah, because it's definitely a common question and many women struggle with that. So
Kelly, you talked a lot about oophorectomy and chemotherapy, and there was a question about radiation and mortality. Do you have a little bit of insight on that? So I'm assuming this was radiation for the treatment of a BRCA breast cancer.
Yeah, and we haven't really seen any survival advantage associated with radiation therapy in BRCA1 and 2 carriers. So it's typically something that goes along with your surgery. So we know in the sporadic literature that for sporadic breast cancer, that women who have a lumpectomy need to have radiation for that local control of the cancer. Some women are now also receiving radiation with a mastectomy. So it's really going to be individualized based on the clinical presentation of your breast cancer, but no evidence in terms of survival advantage in BRCA1 or 2.
Okay, thank you. There was a question about, and this is something that you would discuss in more detail with your genetic counselor, and someone was asking, or a few individuals were asking about BRCA1 and 2 and differences in cancer risk. And yes, the risk of developing breast, ovarian, or other cancers does differ in BRCA1 and 2 mutation carriers, although the risk is still quite high. And so I guess that's a general overarching answer to that. Mm-hmm. But we do know that the risks differ in women with the BRCA1 and 2 mutation. So for example, when we talk about the risk of developing ovarian cancer, the average age at onset is a little bit later in women with the BRCA2 mutation. And that's why the recommendation for preventive surgery, so removal of the ovaries and fallopian tubes, is a little bit later. So again, it is important to know which mutation you have. And again, that would be a discussion with your genetic counselor, and they would give you more detailed risk estimates. There was a question, okay, about recordings, age, being referred. So referrals would happen through your family physician. The SCREEN project is a self-referral, so you could just sign up for that on your own. Someone asked about other cancers, such as prostate cancer. Dr. Vesprini talked a little bit more about that at the last session.
So if you're interested, you could go onto the website and look for that recording, because he did a very thorough job of talking about the other cancers.
Okay, so we're nearing the end. There was one more last question about what to do if you have a mutation, you've already had a mastectomy and oophorectomy. So it seems like, again, that's another more personal question, but you know, you've done the right thing in terms of managing your cancer risks and improving your overall outcomes. Mm-hmm. Anything else for keeping healthy would help you with respect to your overall health. So I think we've answered most of the questions at this point. I want to take the opportunity to thank Dr. Metcalfe for a very interesting and very exciting research that's going on right now with respect to rapid genetic testing and access to care and improving our different, or not improving, but looking at different models of genetic testing and genetic counseling to improve access around the world and improve access for individuals living all over the world. And we want to thank you for participating in these seminar series. Like I mentioned, they're posted online for you to access and to share. And I'm trying to find the slide for the next session that I will post, but that won't be happening until September. So we're taking a break for the summer. And we will be reconvening in September. And if I could figure out how to share my screen, I could post this for you. So our next session is on September 17th. So it'll be a couple months until we meet again.
Oh, it ended. So our next speaker will be Dr. Kotsopoulos. So I'll be manning the questions by myself next time. We're switching roles for our September conference. So I would encourage you to register for this. Let your relatives know, anybody who you think might benefit from this, that this is an overview of how to manage your risk of both breast and ovarian cancer. So I would encourage you to register for that. And also know that we are recording all of our sessions. So like Joanne said, you'll be able to find that on our website if you think that there would be someone who would benefit from hearing some of the sessions that we've been offering. I'd also like to encourage you to let us know if there are topics that you would like to hear covered. So we're starting to think about next year, 2022, and the type of sessions that might be of interest to you. You can email us directly and just let us know. We'll start to keep track of that because we want to make sure that we're answering the questions that you have. So please let us know if there are topics that you would like to see covered. So with that, I think we'll say goodbye. Thank you for joining us again. Have a wonderful summer. It sounds like we might be back to a little bit more normal. So enjoy this time with your family and your friends. I think we all deserve to spend some time with our family and friends, and we will see you back here in September.
Thank you, everybody.
Bye-bye.